Hi, Esther. You are the first person to show up today, so I hope you're having a good Saturday so far. And I don't actually have any questions that were submitted in advance. So if you have any questions that you want to ask, you could put them into the chat, or you could come on screen if you're comfortable with that, and we can talk. Sometimes these sessions just end up being us talking with the folks that show up, and you get a little bit of like an extra coaching session. So whatever you're.
I actually don't really have many questions. I was just jumping on.
Okay, well, here comes Christina. So
Okay, great.
no problem. If you think of anything, Esther, of course you can ask.
Okay,
Hi, Christina. I don't have any questions that were asked in advance for today, so I'm mostly just taking questions from you guys that are here in the chat. So if you have anything that you want to ask or talk about, you could come on screen and we can talk about it, or you can just put on your mic, or you can post it in the chat if you don't want to come onto the screen. But I am happy to take questions live. There's anything in the chat yet. There's not. Esther said she didn't have any immediate questions, but she might come up with one later. So if you have any, Christina, you're welcome to go first. And I'll look at, let's see, thinking about the questions I've been answering in other Q&A sessions recently. If there's anything that I was thinking that needed to be addressed more. I have a whole spreadsheet here, so I'll be looking at this for a second to see if there's something that I feel like we should talk about. This is my first time ever not having like a whole bunch of questions to just jump into. It's kind of relaxing, but not that functional for you guys. Let's see. I talked last night with a woman who has one child, and she has been struggling to have a second child. And she has a lot of symptoms that had made me think in a previous, like at the first time that I'd met with her, that she might have endometriosis. And so one of my recommendations for her was that she meet with like an endometriosis specialist surgeon. And she did. She actually met with 3, which is incredible. And they all basically had a very similar thoughts about her, which was that they agreed with me that it seemed very likely that she had endometriosis, but that they couldn't say for sure unless they did surgery on her, and that they did think that it was sufficient enough. The red flags were enough that they all recommended surgery, but she was, reasonably very kind of like anxious about that, because the idea of scheduling yourself for surgery without knowing for sure that you actually need it is a little bit terrifying, like not just because no one wants to go under anesthesia and have surgery if they don't need it, but also because she started to like question herself whether she was going too far, whether she was overthinking this, whether she was being crazy. So we were talking about the things that she has been doing to kind of like come to the conclusion that she is actually going to do the surgery. And so I can talk more about that after, but we had another person join, and I just wanted to say, I don't know what your name is, but you're in Denver. I didn't have anybody submit questions for today before the session. So if you have questions that you'd like me to answer, you are welcome to come on to screen or put on your mic and talk to me. And I will absolutely be happy to answer your questions, or you can put them in the chat if that's more comfortable. But let's see, we have a question in the chat from Christina. Traveling in May, wondering if I should be mindful about airport screening because she'll be 20 weeks pregnant. I think I will opt out for safety. I've also been taking levothyroxine because my levels, she means her TSH levels, are a bit higher. Everything has leveled out. Thank goodness, wondering if it makes sense to retest at any point. So the levothyroxine question is a lot easier and like more certain. So it's a good thing that your TSH levels have returned to a normal, healthy level for pregnancy with the levothyroxine. Hi. I think we're all kind of like just waking up. I don't know why. Usually there's a ton of questions for these sessions. I'm not complaining about it at all, but if anything comes up for anybody, just pop on or put them in the chat and I will answer them. I have to keep going back and forth between the chat and the participant list to make sure I don't not add somebody if they come. So it's a good thing. It means your body's responding well to the levothyroxine. We love that. That's exactly what we want to see. And it is almost always, if not always, exactly what we do see. So it is great that that medication exists for us and we can supplement thyroid hormone. So now that your levels are back in the like 2.5 range, my expectation is that your OB is actually checking your TSH at some of your routine blood work. The schedule on which they do that, I can't necessarily say for you, but you probably at 20 weeks are slowing down in the number of appointments that you're having with your OB. You might have been going in every 2 weeks up until this point, and you might now be slowing down to like once a month. So they might draw some blood at every appointment or every other appointment. I think you could ask them whether they already have that kind of in their schedule. And if they do, then I think you're pretty good letting them monitor it on their schedule. If it's not on their schedule, it definitely should be because you are on levothyroxine for the first time and you're pregnant. It's not because we're expecting your TSH to suddenly rebound and go back up again and you need to increase your dosage, but sometimes that does happen. So it is good for you to get your TSH monitored. I would say minimum every 6 weeks during pregnancy while you're on levothyroxine, especially because you've been just put on it. That's not to say that we're expecting you to go off the medication. You're going to stay on it the entire time you're pregnant. You may stay on it while you're breastfeeding. If you are hoping for another pregnancy fairly soon after the first one, you may stay on it even longer than that just because it's part of sort of planning for the next pregnancy. But it kind of depends on what your levels are. Some people have incredibly stable thyroids. Once they get thyroid hormone supplementation, they almost never need to switch their dosage. And some people have very chaotic sort of like introductions to the drug, and it takes a while for their bodies to settle in on a good level. So we just don't really know. We expect most people are like me, where the level really never changes. And I've been on the same dose since I started taking it, but we never really know. And since you're pregnant, we want to just monitor it a little bit. Now, the airport screening is interesting. They have that full body scanning stuff. And it's been around for a while. I don't think that there is any clear evidence that it is dangerous, but they do have I believe, an option to opt out of it for anybody who is pregnant, I think for small children, for people who have medical devices, things like that. And like, unless you get bad vibes from the people that are going to pat you down, I kind of feel like I would opt out of it while I'm pregnant. I'm not pregnant that often. And it's not supposed to be dangerous, but it's not designed for a health purpose. It's designed for seeking other stuff. So I think if you are rushing and they are making it really difficult on you, or, things are a little, I don't know, the world is a little unhappy these days. And I think airports are part of the kind of border increase in like activity and stuff like that, if it feels to you like it's better to just go through the scanner because it will be the less, you know, noticeable thing, I don't think there's going to be any real reason to have a health concern. But if you want to opt out of it, I understand that, and I feel like I probably would. That's like a non-answer answer. Sorry. While I'm doing this, I'll just Google and see if I see anything new about the scanners. And let's see. Sarah Wells says, of course, Christina, it's always nice to talk to you. It's always so like wonderful to see that everything's still going so well for you in your pregnancy, because it's such a happy thing, and it's what we're all here for. So we need the like hope and the positivity, and you know, the reminder that this does happen. It's not a rare thing. I have tons and tons of clients and patients who are pregnant right now. But sometimes it feels like it's an unachievable thing. Okay, Sarah. I made liver support soup for the first time yesterday. Is it supposed to taste mostly like a beet soup? The beets you used were huge, so checking to see if that's supposed to be the main ingredient, or if the suggestion is based on a smaller size. I do think the size of the beets probably matters a lot. I absolutely loathe the taste of beets, and so I cannot eat that liver support soup. I can eat all the other veg that's in it, and I like prepare it in other ways, but the beets themselves have this like dirt taste that I don't love. So I personally think the beet taste does take over the soup, but other people might chime in and say that they put more of the bitter greens in, then that covers up the taste of the beets. Different varieties of beets may make a difference. You might like the yellow ones more than the red ones. And beets really do vary in size. Like they can be kind of like small potato size, or they can be like, you know, fat, like daikon size. So you probably want to use somewhat smaller ones. Are you making enough for multiple servings, or are you making it and then just eating it all in one serving, or one day? Hey.
Hi, I can turn my audio on.
Yeah.
The beets I used were like the size of my fist, so I only used two.
Yeah, so like those aren't the largest beets, but they're pretty big.
It made a big container, and I just did the like 8-ounce serving.
So you
So
probably have like 4 servings or something from it.
it looks like more than that,
Even more
but
than 4.
yeah.
It's always going to taste a little bit different based on how you combine the ingredients. And I think the ingredients are they're a guideline, just like any recipe. The goal is to get those vegetables into your diet on a regular basis, in high quantities. So this is a vehicle for doing that, so that you don't have to come up with 10 recipes where you incorporate beets in, you know, 6 different ways, and you incorporate dandelion greens and bitter greens in like 6 other different ways. So you can alter it. You can add other seasonings to it. You could add other vegetables to it. You could also decide, if you love it being a beet soup, but there's something in there that like makes it a less appealing beet soup, you could take that out and eat it in another way, or vice versa. If you like it better as a more green soup, you could take the beets out and prepare them in a different way and eat them separately.
Okay, cool. Yeah, I think I have a history of disordered eating, so I'm trying to figure out what parts of the egg quality diet feel
Good for you.
good, without being so restrictive that it like shoots me back into bad behaviors. So
Yeah, so you really have to listen to yourself. You have to like trust yourself, and be willing, like be open to being creative with it. It's not just those of us with disordered eating challenges, but really all of us like have limited time and energy to focus on things, and aren't like in culinary school, you know, just devoted to learning how to cook new exciting things. So we tend to lean on something like the recipe for the liver support soup, like, okay, I'll just make this exactly the way it is and eat this exactly the way that it says in the book. And you really don't have to do that. Like the goal really is to get those particular vegetables in that general quantity and
that density. Yeah. Okay. Okay. That's helpful. Thank you.
I like a lot more things roasted than cooked in a soup. I'm a very picky eater, so you always have an empathetic, supportive, like person in me when you complain about having something be hard to eat. I'm like, it's hard. It's my struggle. Yeah. Let's see what my Google fingers tell us about the latest technology with pregnancy. Is it safe for pregnant women to go through the TSA scanner? Yeah, as I suspected, they say that they're all entirely safe for pregnant women and babies. They are. Let's see what they say in Australia. I always check lots of different sources and different countries. They say that it's a low frequency electromagnetic field designed to scan for metal objects, which is what I said before. It says that it is considered safe for everyone, including pregnant women. This is also true for the handheld wands, which would be the things that would be used on you if you didn't do it. Some airports have a full body scanner, which is different and can detect non-metal objects. So this is the one that I think that I would be wanting to opt out of. This uses a backscatter X-ray system using low intensity ionizing radiation to see through clothing and spot concealed items, but not penetrating the skin. So it's called an X-ray system, but it is safe to go through. But you can refuse. So I think the metal detector type things that you walk through, that you're used to walking through whenever you go to a concert or you go, anywhere, you're probably walking through those when you don't even know it, like into a bank, things like that. And those really are looking for metal, and I don't think those are dangerous to your pregnancy. They've been around for decades and decades and decades, so I think they're well established to be safe. And a lot of the stuff that, like, I'm sitting around right here in my office, like my iPad and my laptop and my external hard drive and my iPhone and my printer and my router, like all of that stuff is also emitting a little bit of electromagnetic waves on a low level, and we live with those things all the time. And I think the risk of the regular metal detector is pretty similar to that. It's the full body scanner, which in my head, I'm not seeing any pictures of it online, but I remember when it was released, they would, like, the news had pictures of sort of like how they could see your whole body. People were worried about whether, people would be able to see them being nude or anything like that. Like if it can see through your clothes. I think that's the one that you might opt out of. And I think it's really just for an abundance of caution and like comfort, because if we don't have to go through it, why go through it? But like I said before, if it feels like you're running late or like you're getting backlash from the people, you should make the choice that feels the safest and the most comfortable for you. And that could be either going through it or opting out. I hope that makes sense. I wish we didn't have to have these kinds of concerns in our pregnancies, or really just in general, but that's what I think. The the like full body thing that does use a little bit of x-ray has been around for a long time too. And we haven't had any kind of like new concerns about people who are pregnant. So I think I'm not worried about it. Any other questions, guys? Or concerns or just things you want to share? This does get recorded, as you guys know, so other people in the group will see it later. So I always point that out just in case people don't want to talk about something personal. Everybody's excited for spring, like ready to be able to go outside a little bit more and like not have to be bundled up in your coats if you live in cold weather. Hopefully everyone, even though you're actively trying to conceive, hopefully you're going to plan some vacations for the summer. I was talking about that. Oh, I'll go back to the endometriosis, but I was talking about vacations yesterday also with someone. She's having a frozen embryo transfer coming up in June that she's currently doing a depolupron suppression for 2 months before because she has adenomyosis. And May is her 10th anniversary with her husband. And so they're going to go away for a few days. And she was asking about like having a little bit of alcohol and like having a little bit of gluten and everything. And I was very encouraging that she have a good time on her trip for her 10th anniversary with her husband right before her embryo transfer. It's not in the same cycle. She'll still be suppressed. She doesn't have any major reactions to gluten. She eats according to the egg quality diet all the time. Most of the time, she has very little alcohol. Most of the time, she's not planning to go crazy on this trip and like get drunk or, binge eat or anything. So I was like, please just have a good time, like enjoy yourself and your husband. Don't think of it as, super restrictive. Don't eat things that, make you feel really bad and, make choices because we'll always make choices on the menu that feel good to you, but choose to let loose a little bit and then not to beat yourself up about it. Like make the decision, commit to the decision, know that there are reasons why we make these decisions that are not just about whether something is inflammatory or not. And then don't look back, enjoy it. So the other girl I was talking about who was trying to figure out whether she should have surgery for her endometriosis or not. She lives in Kentucky. And so the reproductive endocrinologists there, she's seen a couple of them, I had suggested, and I think the endosurgeons had also suggested that she try the Receptiva test. And the doctors there were very discouraging of it, saying, no, this doesn't do anything. It's a waste of money and time and going in and taking a sample from your lining. And, we don't recommend it. We don't think it'll find anything. But I had encouraged her to do it because actually last year in 2024, there was some new findings that were released that show that the Receptiva test is actually more accurate than we originally thought that it was. It is a relatively new test. So when it came on the market post-lockdown, like maybe it was 2020, maybe it was 2021, but it is, in the last 5 years. At first, all the doctors everywhere were very hesitant about it because the test itself, they take a little biopsy sample from your endometrial lining and then they test it for a protein called BCL6. And if you have a test that's positive for that protein, then you have a higher chance of having endometriosis. If you don't have a test that's positive for it, if it's negative, then you could still have endometriosis. The test really hasn't told you anything. The girls who have it positive, when we first started using this test, it was a higher chance, but you didn't know how much higher. So I understood that it seemed like kind of a waste to do because it didn't really tell you anything. But last year in 2024, they have more information because more people have had it. And it's now accepted that if you test positive for that protein, you have an 85% chance of having endometriosis, which actually is a very high chance. It's not 100%, but it's a very high chance. And so when you're faced with a decision like she is, should I have surgery or not? It seems very logical to go and have this biopsy done, even though it costs money and it requires them going in and taking a sample. And even though it's not 100%, because it's still so much less invasive than surgery, it's so much less expensive, so much less time. And if it was negative, maybe she would decide not to do the surgery. So she did do the Receptiva, but she had to travel to Chicago to get it done because none of the doctors in Kentucky would do it. And it came back not just positive, but they also now have added, and I really have to go and like read up on it. They now are giving almost like little gradings, and it had a pretty high result. So she took the test back to 2 of the 3 surgeons, and one said, "Oh, that high result means that this is a stronger likelihood of endo," and the other one said, I don't really know how to interpret these like sort of grade results. I kind of ignore them, but the fact that it's positive is enough for me. And so because of that, she has decided to go ahead with surgery. And I think she's going on Tuesday next week. But I think it's an interesting thing because sometimes we're here in the New York area and we have all of this interaction with doctors. And so we sometimes act like or talk like it's really easy. I don't know if we really do, but sometimes I worry that we make it sound like it's really easy to go off and get tested for everything, that there's a specialist in your area that is just going to like immediately agree with the need for the test and to support you and assist you in that. And like sometimes there aren't. And some of you have to travel really far for all kinds of things. We're really aware of that, of course. And this idea of endometriosis, another thing that came out last year in 2024, which has changed the way that many of the reproductive endocrinologists talk about endometriosis now, is that they have, collated a bunch of research and done sort of like a meta study. And now there's an expectation that maybe 50% of unexplained infertility is related to endometriosis. It's not set in stone, but it's an interesting finding, an interesting change in how the scientists, the researchers are thinking about challenges in getting pregnant, because prior to this, there were some people who were including endometriosis as something in the mix that might be involved for some people, but without as much support from sort of the research. And there were many, many doctors who were just saying, no, don't worry about that. It's not important. It's not relevant. And now I think, at least in New York and in bigger markets, and it's changing slowly in other places, they have more research where they are going to take endo more seriously. And so I certainly have seen an uptick in doctors recommending Receptiva, and when the Receptiva comes back positive, recommending treatment. And I expect that is going to filter out even to Kentucky eventually. And so it is going to come up more, maybe not for each of you individually, but like in groups that you're in with other women, even just with women that you meet, now and in the future in your life. And it, it's like it's a big kind of scary unknown, but it is also really good that we have all this focus on women and endometriosis and like trying to learn more about these connections. So this girl is going to have surgery. The other option is to do the suppression that the other girl that I mentioned before is doing. She doesn't have endometriosis. She has adenomyosis, but it's the same type of suppression where they suppress you with usually Depo-Lupron, but sometimes they'll use Orilissa or Lisa. Yeah. And when people do that suppression, what I read online and what people often say to me is that they are being temporarily put into menopause. That's kind of the sort of phrasing that people use. Or if people are considering that suppression, they come to us and they worry about being put into menopause. And I think that we should not talk about it that way. I'm trying to destigmatize and participate in making perimenopause, menopause, postmenopause, those phases of a woman's life and those experiences that a woman has in those years, something that is less scary and foreign and more something that people have enough familiarity with to feel that they have an understanding of what it is and what it isn't. And it is, you know, for the most part, I would say that if you polled the general population, they would say that people who are trying to get pregnant are afraid of menopause, but that people who are trying to get pregnant and people who are entering perimenopause or are in perimenopause, they can't be doing both things at the same time. And that is totally not true. Like, nobody knows how long perimenopause, which is this phase before you enter menopause and postmenopause. Menopause is really a moment in time when you have had 12 months without periods. Perimenopause is all the time kind of leading up to that, where you're having less frequent irregular periods and where some women are having a lot of symptomology, right? The hot flashes and all the other things that come up in that phase. But women get pregnant during perimenopause all the time. It definitely happens. It is the later stages of it are where a woman is approaching 12 months without a period, but through most of the time that she's having disruption in sleep or having hot flashes and night sweats, most of the women that I meet are having periods every month regularly, or they are having them most months and then only skipping a few months. So really, there's no reason to think that having any of that stuff start to come on is the immediate end of trying to get pregnant. There's a lot of room to push into that, and to push as far as we can, really, if that's what's right for that person. So going back to the Depo-Lupron and the Orilissa, I think it's too scary to call that stuff temporary menopause, because it's not what it is. It is using medication to shut off temporarily the production of certain hormones in your body that feed the tissue that you are trying to control. So you're trying to control the adenomyosis, or you're trying to control the endometriosis. These are both conditions where there is endometrial lining tissue, the tissue that we grow in our linings in order to be able to implant an embryo, that then, if we're not pregnant, gets the message that it's no longer needed, and it sheds, and then it is passed out through the cervix and the vagina. And that's the blood that we see, that's the menstrual blood every month. And when that type of tissue grows in other places, it can be problematic. So endometriosis is where it's growing outside of the uterus, and it can grow anywhere, but the most common place that it grows is in the abdominal cavity. So it could be along the abdominal walls, it could be along the outside of the uterus, it could be along the bowel, it can sometimes be around the ovaries and the tubes. It can be in the down in, a lot of times it's down in the pelvic area, near the pelvic bone. But it could be in other places too. And when I say that, that's too vague. I shouldn't be so vague. Like like a classic medical school textbook example is a woman who gets a nosebleed every time she gets a period because she has endometrial lining tissue growing in her nasal passages. And when that gets the message that it's time to shed, and so she actually sheds and has like a little period from her nose. I've literally never seen that, but it is a classic example. So it could grow anywhere. Adenomyosis, adenomyosis, it's the growth of that endometrial lining tissue, instead of it just being on the inside of the uterus in that like detachable way where it can be shed and leave the body, it's growing through the walls of the muscle of the uterus, through the muscle. And so you can't remove it surgically the way you could technically remove the endometriosis tissue surgically, because you're not going to cut into a woman's uterus when she wants to use it to be pregnant. Because they can't do any type of surgery for it, the only treatment is to suppress the hormones that cause it to grow. So when it's adenomyosis, they usually are combining the Depo-Lupron or the Orilissa with letrozole, because that has better results for adenomyosis. For endometriosis, they don't necessarily need the letrozole. But this temporarily pauses, or in the case of the Orilissa, I think it only mostly reduces your body making like FSH and estrogen. And then the tissue, which feeds mostly on estrogen, has less of the hormone that allows it to grow and flourish. And so it kind of withers away and dies. And it's kind of like winter, where the trees and the plants all look kind of dead, and the plants that are, flowers and things that are really small, that don't have like a branch-like structure that can survive a winter outside, they all like disappear, and it's just the roots underneath the ground that are still there. And that's the purpose of those treatments. So the symptoms that people have that they're referring to when they say they're being put into menopause are these perimenopausal symptoms that are related to reduction in estrogen. And so I have like 2 or 3 girls that are doing it right now, and I always ask about the symptoms. I always, check in on what they're experiencing. Most people do experience some hot flashes and sweating. Some people also experience headaches. Some people experience disruptions in their sleep, like they feel like they wake up more often, or they are lighter sleeper, something like that. But I think it's better to understand them as symptoms that happen in our bodies when we take away estrogen, because the purpose of that treatment is to take away estrogen in order to resolve the tissue so that you can go on and have a healthy pregnancy. And I feel like it's important it's important to take everything seriously. And I'm not like saying that there aren't any potential downsides or risks to something like that, but it isn't the same thing as being put into menopause. And I don't think you should fear that by doing it, you might be put into menopause and never come out of it, which is the big fear. Sarah has another question about getting more diagnostic tests. Yeah.
Yeah. Hi.
Hi.
So I think I might have answered my own question while I've been thinking about how to ask it, but I'll ask it anyway.
Sure.
So I'm in Colorado, and I'm super lucky because Colorado this year mandated fertility coverage by employers and insurance. So
Yeah.
that's awesome. And I've been through 2 IUIs and 4 rounds of IVF with a clinic here, and now I'm here as I think an option that feels better for me.
Yeah.
And because I didn't get any embryos from those attempts. And my doctor, like my last sort of message with them before pursuing this route, I said, okay, like if it's a numbers game, like statistically, what are the chances for me? And she said I had a less than 10% chance of live birth based on previous rounds and based on my age, which Amy and your group is saying that's a lazy diagnosis. Let's dig into what it actually is, right? Which that feels great.
Yeah.
But I'm feeling like, at least like you know, before my last round of IVF, I went to the doctor and was like, what about PRP? What about Omnitrope? What about this? What about this? And the answer pretty much every time was there's not enough research that links it to live births. Um, so she's not feeling like a great partner, and
Yeah.
I'm feeling like I haven't asked yet, but my just gut sense is that when I say, can we do a hysteroscopy? Can we do this additional testing? Like if that's what your team ends up recommending, that she's not going to be down. um,
Yeah.
and I don't know that, but is it just like, is there a reason energetically to just start with a fresh doctor, or is there a lot of benefit to sticking with someone that has all of my testing?
I can see either thing being good, depending on a few things. So, first of all, while I can't promise that everyone can find a doctor that they feel safe and supported with, I do think that you deserve to feel safe and supported by your doctor, right? And so I think that should be on the table of things that you're looking for, not something that you think is a pipe dream that just can't like happen. And I don't think that not having had success in your previous cycles is a reason why you couldn't feel safe and supported by your doctor, but some of this stuff after that, it starts to feel that way. And sometimes starting on with a fresh person means you leave some of those experiences behind, and you're kind of wiser and more intentional about how you like set out in the relationship with the new doctor, what you tell them that you need from them and expect from them. And that sometimes results in a relationship that feels better. So that might not be about the medicine. That might be about the energy, or about like how you come to the table and how you understand what you need and your comfort level with advocating for yourself. Right. I always say, you cannot be the most demanding fertility patient. Like you could make it your life's mission to try and still fail.
Mhm.
There are women who are making these doctors absolutely bananas, right? Like you can't do it. None of you could ever do it. You guys are all so like responsible, caring. Like that's not to say that you don't have your moments when the anxiety takes over or when something makes you panic. Like, but that's okay. Was that a Taskmaster mug that you just drank out of?
Oh, no, I have a 5-year-old. This is
Oh, a 5-year-old. Okay.
a picture.
Um, yeah. So like, I feel like you can't be too demanding. So my rule is kind of don't be a bitch, but I kind of think that's my golden rule in life, right? But advocate for what you need. So the things that you are talking about now are things that you are not unreasonable for wanting and that people are having done all the time. Now, the type of clinic that you're at, and like I was just talking about this girl in Kentucky, sometimes we don't have a lot of choices. We are limited by what we have available. And sometimes we don't even know until we get into the situation what we actually have. The type of clinic that you're at is going to determine to some degree what they are willing to do with you. And that's not really fair to you guys. But that is a feature of our medical system. So one thing I always say is you should not expect a doctor to talk to you about, and most of the time not encourage any service that they don't provide at that clinic. So when you get into PRP specifically, most places don't do it. So the places that don't do it will not talk about it, will not tell you it's an option. And if you bring it up, they tend to be at a minimum kind of like neutral about it, and sometimes pretty discouraging. I usually say don't blame the individual doctor for this, because most of the time she works for a corporation or a hospital or something, and there's a whole lot of layers of bureaucracy over her where other people are making decisions about what she's supposed to talk to you about. And so if she's not going to be able to do something about it because it's not part of what she's allowed to do there, her goal is to get out of the conversation as fast as possible, right? That puts you in a difficult position, because you then have to be able to intuit when it's not really something for you and when it's something that she can't really offer you. And that's really not fair to you. And that's part of why we try to provide the help that we try to provide, because you can't just know all that stuff on your own.
Yeah, I think what happened is so in Colorado, there are like two big ones. There's CCRM and Shady Grove, and both of them have offices all over the country. And I chose Shady Grove because it's the one that's not currently owned by private equity. So
It's smart.
yeah. And I think what I'm realizing energetically is I gave them 100% authority just mentally, because I was brand new to the whole thing, and it was a really devastating process.
Yeah.
Because their end assessment was, it's not going to happen and you're too old and too fat.
Yeah.
So
yeah, I mean, in the year of our Lord 2025, right? Like, could we just stop already with all of this? Yeah. In our experience, Amy and I talk about this pretty regularly. I'd say maybe we feel like PRP is kind of 50% successful, which means that for the 50% of people where it doesn't seem to really improve the outcome, it doesn't seem to do any harm, but it just doesn't seem to improve the outcome. There are a couple different ways to do PRP. You could do a single PRP treatment, or you can do a series of multiple PRP treatments. All of the research about PRP, not just ovarian PRP, but everywhere on the scalp, for hair growth, in the knees, like everywhere, seems to be that repeating it multiple times, it causes it to have an increased success. That it's not just that you're having it done again, but actually that like introducing those growth factors then like promotes the body's ability to use those growth factors. So a series of PRP is potentially more helpful than a single one. And then Murphy's the only one in the US that's doing the adipose PRP, but the adipose PRP is another way of doing PRP. So regular PRP, platelet-rich plasma, they draw your blood and then they spin it to separate different components, and they separate out the liquid part, which is the plasma, and one of the types of blood cells, which are the platelets, and then they make like a super like potent kind of like cocktail of those things, and then they inject them into the ovaries. And by doing that, they're delivering high concentrations of the growth factors that are already circulating in your body. But when we were younger, we had higher concentrations of these growth factors and we were more responsive to them because we were in a period where everything was growing. And then when we hit 25, that kind of stops for everything and we stay alive. We don't just immediately keel over, but the way that all of our cells and everything remain alive and grow and replace themselves and everything is in a like, it's in a different phase. It's not in the phase of everything growing. It's in the phase after that where nothing's really growing that much. It's just kind of, repairing. And it gets slower and slower and slower, in our 90s, it's going to be even slower. And so this is a way of like kind of reintroducing this more youthful functioning for a period of time. And when they do adipose PRP, they take what I always say is a liposuction from your abdomen that's too small to be cute. Like it's not going to make you skinny. But they do take a little bit of fat because our fat cells have stem cells in them. So when I think they don't have to do this anymore, but in exactly this way, but when we like used to hear about people getting tested for bone marrow transplants and things like that, what they take out of the bone marrow that has all of these like stem cells in it is actually kind of fat. Like it's very closely related to fat. So where they can take stem cells out of your fat cells without having to go into your bones. And then those stem cells can like, they are from a younger stage of development of cells, they have more opportunity to develop into more. And so we just had a girl who really retrieves like like 0 to 2 eggs each cycle. And she just retrieved, I think she retrieved 9 eggs in her first cycle after her adipose. And she did make blasts, and she did have one, I think it was only one euploid blast, but she did have a euploid blast. And I can't promise that it's always that dramatic, but it was pretty dramatic. And it really, all of this is the reason why having policies that say that we'll only do X, or we'll only do X in these circumstances and only add Y in these circumstances, and then once you've hit these circumstances, then we might do Z, is challenging, is that biology is very varied. And so one woman, all we need is to find the thing that your body responds to that helps you. And we don't really need to care like whether it was something that other people didn't need because they responded to something else. Like, yeah, right. Yeah. But some of those kind of bureaucratic things start to limit that. So PRP is relatively easy to travel for. It's expensive, but it's like cheap compared to IVF, and it's probably not covered by insurance anyway. Right. And it is relatively easy to travel for because you can travel and travel home and things like that. So if no one wants to do it in Colorado, you could. A hysteroscopy, endometrial biopsies, the girl from Kentucky, that story that I was talking about before also proves that you can travel for that stuff too. You don't actually have to have the same doctor that does an IVF cycle do those things. It's nicer when they can do it, when you have one relationship with one doctor, or where you have
Can an OBGYN do those?
Yes, an OBGYN can definitely do a saline sonogram and a hysteroscopy. If you had anything like a polyp or a bit of scar tissue or something, an OBGYN could remove it. Not all OBGYNs will do it. It kind of depends what they do in their practice, but they are all trained in it. And some of them do it regularly. The weirdness around abortion could be limiting what OBGYNs feel that they want to do in their office in some places. And I hate to bring up politics twice in this thing, but like, we just have to be aware that, like, again, you may get a no answer, and then you have to think about like, what are all the why I'm getting a no. Like,
that might actually be the case with mine, because I think the hospital is a
Catholic
hospital, and so she took my IUD out, but she said I can take this out, but I'm not allowed to put a new one in.
Back in, yeah. So. A hysteroscopy is not a DNC, but they are not that far away from each other. So like, yeah, I think you do better having someone who does them more regularly do them. So if your OB says, oh yeah, I don't do that often, but I could do it for you. Like, if it's the way to get it covered by your insurance and you otherwise couldn't afford it, I'm probably going to say like, oh yeah, definitely go ahead with this. But if you have other options, I'm going to say like, maybe we should consider somebody who does them more frequently, specifically related to fertility. Because you'll get more information out of that doctor. When they do a hysteroscopy just to like make sure there's nothing obviously glaringly problematic in the uterus, they're like just looking for big stuff. If they are doing a hysteroscopy for the big stuff, but also within the context of like trying to get this girl pregnant, and especially when it's their patient that they want to have the success with, or when it's something that they specialize in, they may look around a bit more. And like, even the reports I read vary a lot in terms of how much information they give about what they saw and what they did.
Okay. Yeah. So sounds like interviewing some other doctors in Colorado and considering. So
I would say also that a second opinion from a reproductive endocrinologist is often a really good thing. And it is not something that you only do when you know for sure you're leaving your current doctor. It can be something that you do and you still stay with your current doctor. But
Mhm.
taking your chart from Shady Grove to CCRM or to someone else and having them look at it and them talk to you about what they see and what they think, you are still going to have to like go in shielded for the donor egg, like thing coming up, for any of the stuff that, or you go in saying, I'll hear what you have to say about that, but I just want you to know at the outset, that's not really what I'm looking for. That's not really what I want to talk about.
Mhm.
I understand that that's an option, but that's not what I'm doing right now.
Yeah.
But sometimes you get really good information from them because they have more information to work with than they did when you went the first time before you'd done any IVF cycles, and they all know each other. They all go to the same conferences. They all read the same stuff. They all do the same, continuing education. Like, but they have a different relationship with you when you're not yet the patient. They have more freedom when they're like marketing their services to you, and also when they're not responsible for you.
Mhm.
Right.
Mhm.
And
Okay.
sometimes you get different information.
Mhm.
Yeah.
Okay.
I think
That's useful. Thank you.
that's valuable. I think I wouldn't be pessimistic that not encouraging you to do PRP means that they wouldn't be open to a hysteroscopy or an endometrial biopsy or something like that. I think they're a little bit different. I think that if anybody refuses you on any of this stuff, it's not your only option, and you are not being like I said about my other patient, like she was thinking, am I being crazy? Am I like doing too much? Is this unnecessary? Like, no, it's not.
Mhm.
It's not.
Thank you.
You're welcome.
Yeah.
Good luck. And I'm sure I will see you in a group session soon. And I always like meeting you guys here. So yeah. Anything else anyone wants to ask or talk about or anything? Well, I'm glad you guys came on. I never know if the timing of these sessions, like I fit them in around my schedule, and I haven't figured out whether you guys prefer early or late or weekends or, weekdays or anything like that. But I'm really glad you guys came today and I got to see you. And I hope everyone has a really good weekend. And that, like I said before, that you are making some plans to do some nice things for yourselves in the spring and the summer, because even while trying to conceive, you also need to take care of yourselves in other ways and have some joy in your life. And what did you say, Christina? You wish you could carry. Oh, thank you. Little pocket, Sarah. I wouldn't mind. All right. I am gonna go, and you guys have a great day. And I will see you all soon. Bye, guys.